If you can just let me know, Anthony, as soon as you've let everyone in that's in the waiting room, and I'll get started.
Okay, I let everyone in that's in the waiting room, but I will let them in as they trickle in.
Okay, I'll give it one more minute.
Okay.
All right, I'm going to get started. Welcome, everyone. My name is Maria Picconi, and for those of you who don't know me, I am the co-founder and CEO of Trend Community, and I'm also mom to a 13-year-old, Taya, who's living with PWS and narcolepsy. And we're here today to shed light on sleep disorders in Prader-Willi syndrome. We have a really packed agenda, so we're going to get started straight away. But this meeting is being recorded, so anyone who misses it or comes in late can watch the recording later. And we encourage you all to share the recording as well to continue to raise awareness about sleep issues in PWS. This topic is especially important to me. Here at Trend Community, we use social listening technology to analyze conversations happening on social media in order to broaden our understanding of rare and chronic diseases. And one of the first observations that we made back when Taya was very little is that our community was talking a lot about sleep issues, as well as some unusual behaviors, such as faking sleep, head bobbing while eating, sudden loss of balance, and sleep attacks. And so, in partnership with doctors Amy Ravana and Dan Glaze at Texas Children's Hospital, we began to connect the dots to better understand how sleep disorders manifest in PWS. Today, many in our community, including our daughter, have been diagnosed with narcolepsy, and many more are impacted by excessive daytime sleepiness. But because our babies are born so sleepy, sleeping 24/7 if we'll let them, it becomes very difficult as they get older to identify sleep issues and truly understand how they impact our kids' daily lives. I'm joined today by an amazing panel of caregivers and clinicians who are going to share their experiences and perspectives, and we hope that this will empower our community to recognize these symptoms and seek treatment. Let's start with some introductions. Dorothea, why don't you kick us off?
Okay, thank you so much, Maria, and thank you all for joining us today. It's really exciting to be here. I'm sure that I've had an opportunity to meet a lot of you who are attending today, but for those of you who don't know me, my name is Dorothea Lance. I'm the Director of Community Engagement with PWSA USA. But most importantly, I have an 8-year-old son who is living with PWS and who also suffers from excessive daytime sleepiness. And I'm just really excited to be a part of this conversation today. So thank you for allowing me to be here.
Lynn?
Hi, everybody. My name is Lynn Garrick, and I'm the Medical Research Coordinator at PWSA USA. I am also mom to John, who is 20 years old and living with Prader-Willi Syndrome, and I also am a provider of group home services here in my home state of Minnesota.
And Elaine.
My name's Elaine Toll. I just celebrated my 1 year anniversary with PWSA. I'm an advocacy specialist working with Dorothea. And again, most importantly, I am the mom to a son named James, who is 39 years old, living with Prader-Willi syndrome and excessive daytime sleepiness. I think we've covered the age range pretty well with the three of us here today.
Exactly. Dr. Ravana?
Hi, everyone. My name is Amy Ravana. I'm one of the pulmonary sleep physicians here at Texas Children's out here in Houston, Texas. I am a strong advocate for the PWS community since at least over 10 years of doing this. So I'm happy to contribute as much as I can. Feel free to reach out. And thanks for joining us today.
And Dr. Chitticle.
My name is Aaron Chitticle. I'm a pediatric pulmonary and sleep medicine physician in Wilmington, Delaware. I work at Nemours Children's Health. I've been working in this space for 30 years, and it's really been an amazing and rewarding journey, along with the kids and now young adults with PWS for whom I've been able to care as they've struggled with respiratory and non-respiratory sleep issues across their developmental trajectory. Thank you for inviting me. I look forward to a wonderful discussion.
Thank you all. This is intended to be an interactive session. We made it a Zoom call for that reason. Please share your questions and thoughts in the chat, and then we'll open things up for discussion at the end. So recently, we did an analysis of the PWS Connect online community and Reddit. And interestingly, sleep and sleep disorders comprise the most common topic that bubbled up across community conversations. And when we looked at medication mentions, pitolisant, which is being studied in a phase 3 clinical trial for people with PWS who experience excessive daytime sleepiness, and growth hormone, rose to the top and dominated conversations. And when we looked at symptoms, feeling tired was talked about more than we've seen in the past. Dr. Ivana and Chitikal, this certainly highlights how important sleep is for this community. Can you briefly share what you're seeing in the clinic?
Go ahead, Amy.
Okay. So we see a variety of symptoms, and a lot of times they're masked as far as the other symptoms of Prader-Willi syndrome. But for the most part, it's the daytime sleepiness, it's irregular behaviors that, are attributed to some things such as cataplexy that could be as tics or tripping frequently or having twitchings of the face, of the lips, slurring of the words. Sometimes, they have problems during the day where they're not able to learn as much as and participate in therapies and whatnot. But at night, they're supposed to be sleepy. They can have a variety of other symptoms of sleep, having trouble falling asleep, having trouble just feeling well rested during the day, but they're sleeping the number of hours or even longer than expected. And we see a variety of ages. Maria mentioned in the newborn infant period, they're sleeping more than normal babies who don't have PWS versus the teenager that you expect to stay up later at night doing teenage things are actually sleeping when and so we see a variety of presentations that are often not really easy to pick up on because of the diagnosis of PWS.
Thank you.
I'll just quickly add to that the sleep in childhood evolves across the life path of the child. And as the demands of the daytime schedule and the demands of the academic schedule and the other developmentally appropriate milestones that children should be meeting, those can be impacted significantly by sleep. And those are things to be aware of as well. It's also important to understand that even dealing with a condition such as PWS, or really any other condition in childhood, sleep is central to growth, development, and health. And so bringing it in as part of the discussion as any child's health maintenance is very, very important. In my own practice, we often become engaged with infants with PWS either because of sleep and breathing or because of other neonatal respiratory concerns. And that's been very, very helpful and rewarding for us because then we stay engaged with the families as the children grow and develop and monitor their sleep and behavior and breathing across childhood and test as indicated.
People are so fortunate to be connecting with sleep specialists like you two early on. We're all getting sleep studies, and yet these things are still missed. What you said certainly resonates with me. In hindsight, there were so many clues that Taya was struggling. When she started eating food in the high chair, she would suddenly just fall asleep while she was eating, or I don't think I've met a kid who doesn't fall asleep in the car, but we just kind of sweep it under the rug. Of course, kids with PWS sleep in the car. And for us, it wasn't really until she was in second grade and really started struggling to stay awake throughout the school day. And in fact, we would send her to school with coffee and tea and just to try to keep her awake through lunchtime so that she could learn as much as possible. Um, Dorothea, Lynn, and Elaine, I just want this to be a conversation about, our stories and journeys. What were the early signs for you all?
I can start just to kind of break the ice here. I think that it started earlier than I would have imagined when I started looking back and thinking about like how tired Hunter actually is on a daily basis. Um, he wasn't he would go to bed when we put him to bed at night, and it appeared like he slept through the night. But I think what started to become an issue was his quality of sleep and us being able to identify what that quality of sleep actually looks like. At 8 years old, it's not normal for him to fall asleep within a minute of being in a car at this point. It's not normal for him to still require an hour to 2 hour nap every day, just to be able to get through everything that he's doing. It's not normal to have to put together an IEP or a plan with his school and say, hey, listen, if he falls asleep on his desk, just let him sleep it out. And I think that it took us reevaluating what our thought of sleepiness actually looked like to recognize that it's not normal. This isn't just PWS, right? There's an additional component here, and he is legit sleepy, and there has to be something that we can do about that, separate of him having Prader-Willi syndrome. And I think that for years, people have just assumed that people with Prader-Willi have, they're just extra sleepy, and no one's started to look at the why. And it's really exciting that we're at a point in research and development in our space where we can kind of carve it out and say, okay, well, it doesn't have to be, right? Let's look at what the reason is that our kids are actually sleepy and see if we can and flesh that out and give them a better quality of life. So it started earlier than we thought, and we didn't start thinking about it until our community was really talking about how sleepiness presents itself in our space, if that makes sense.
Yeah, Dr. Ivana, the nap thing is probably something that I hear so much, especially for those of us whose first kid has Prader-Willi syndrome. So at what point is napping during the school day not normal? Like what does that look like in a normal child or normally typically
So a
developing child?
typically developing child. So usually naps are great for infants and then toddlers. So they usually go from two naps to maybe one nap and then the major sleep period at night. And then, by kindergarten. So that's usually my marker. Kindergarten is when they shouldn't be sleeping in class. They shouldn't have to put their head down. They shouldn't ask to go take a nap. Even on the weekends, right? When you're busy, 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 they shouldn't be nodding off. And around that time also is when you shouldn't be nodding off in the car either. Even adults, typically developing adults shouldn't be nodding off in the car, even for 10 minutes or 5 minutes or on their way home from school or on their way to school. So I use that as a marker, kindergarten. Now, there's a little bit of a deviation. So, maybe pre-K is when you start really noticing that, that 2 hour nap is not enough and they need more. And, they get older and they need even more. So that could be a flag as well. And then, maybe in kindergarten, they don't have naps, but they're napping on their way home from school because they don't want to miss out during school.
Can
Lynn,
I just? Oh,
oh yeah,
sorry.
go
Go
ahead.
ahead.
Yeah.
I was looking at the chat, and I saw potty training. And I think Sherry, you brought it up that it affects speech and potty training and things that our bodies like rely on. Yeah. So we're at 8 years old with PWS, and potty training has been the bane of my existence. And we are I think that part of that is due to the fact that Hunter's had a difficult time developing skills necessary because he's been sleepy or distracted because of his sleepiness. And when we look at our kiddos, and when I say kiddos, I mean like the broad range of ages. I say kiddos because my kid is still a kiddo. He's always going to be my kiddo. But when we look at things like school participation and emotional regulation and just like routines, without the proper rest and the proper amount of sleep, it's going to exacerbate all of these other symptoms that we deal with in PWS. So I think it's super important to be able to address the sleepiness issue.
So let's jump to Lynn. Like, how have sleep issues impacted you and your family and John?
Oh boy. So John, again, is 20 years old. And I think, like many folks, I feel late to the party here. You know, we didn't have the awareness of sleep and Prader-Willi syndrome when John was young. So hindsight, falling asleep in the high chair, you know, for sure, as an infant, as a toddler. But then when we fast forward to school age with him, this was something that he was napping more than he was awake at school. And when he was nodding off or whatever, that was misinterpreted as a behavioral task avoidance thing, right? Oh, he's just a task avoidant kid that he puts his head down. Or then we had to build in 2 and 3 hour naps in a 5-hour day at school because he would just fall asleep. In addition to the falling asleep in cars and stuff. So for him, it was really misunderstood as a behavioral component. And then a lot of the teachers and even some of the physicians that we have worked with, that's just Prader-Willi syndrome. They're hypotonia. That's just what they do. We just have to work around that. But then what did that mean for John was that to this day, he can't read. I mean, that's such a fundamental thing for all of our kids. And, I feel guilt about that as a parent. But he missed out on so many skills and things that we take for granted because of the sleepiness. And so it's just something that we all need to be cued in on, thinking that a lot of us as older parents that wasn't on the radar. That wasn't a thing before. So I think now that we're focusing on these things and have therapeutics, wow, it will dramatically change so many lives. And I'm hopeful that John's life will change also. He's got a lot to make up for because of this misdiagnosis, or there wasn't any treatments.
Thanks,
Just to
Lynn.
interject quickly, if I may.
Yeah.
I agree with everything that Dr. Amy said. And one thing that's pretty straightforward for parents is elementary school age kids are some of the most hypervigilant children that are there. That is a period of time when curiosity takes charge, when those children really do not want to miss out during the day. So napping and falling to sleep in school for any elementary age child is a flag, even for typically developing children. And then the other thing that's really coming out in this discussion as well, and just from a pragmatic standpoint, when a concern, be it a clinical concern or a symptom, becomes such a thing that it really dominates one's life or family balance, it really needs to be explored or hopefully addressed. And yes, we now can address safely and effectively the sleepiness experience by even young children with PWS, and elevating that discussion is so meaningful to that.
I'm so glad you said that, because so often, even as a nurse, I assume that my doctors are experts in kind of everything, and they didn't even mention this. Or when somebody told me that's just PWS, okay. And this is horrible, and I self-disclosure, this is going to sound awful of me, but John was very behavioral. So when he did have these extended periods of sleep, sometimes it was almost welcomed for me because I got a minute of peace. So did that hold me back from getting the diagnosis? I'd like to say it didn't, but there's still that selfish part of me that said, whew, okay, I can relax or do something. But that shouldn't prevent parents, and I didn't know about that before, so I feel extra guilt now.
Oh,
But
don't.
yeah.
That's a real reaction, Lynn. Good on you for saying it, because I think we all as parents live in a constant state of guilt for what we should do or shouldn't do or should have thought of or any of that. I have a question, Maria, if that's okay.
Yeah.
Because somebody in the chat, one of our attendees put in the chat about a sleep study. And I'm just curious if maybe Doctors Chittagall and Ravana can answer this. Is it, if you suspect that, your child or a loved one with PWS is suffering from EDS, is a sleep study, I mean, I would imagine that a sleep study is a good step in the right direction. But is that the only thing that parents can look towards, or can look to as a marker for EDS? Like, how does a sleep study fit into the equation of diagnosing EDS?
Okay, I'll go first this time. So the first part of any medical evaluation starts with a careful history. And what's come out beautifully in the discussion thus far are all of the clinical indicators that raise the suspicion for excessive daytime sleepiness. Falling asleep at unusual times, falling asleep in unusual places, falling asleep during the day despite adequate overnight sleep. And so any clinical evaluation will begin with a discussion of that and whether or not the physician or the person evaluating your child uses a specific tool, because there are questionnaires available to help quantify these things. That's where the discussion will begin. And then, yes, sleep testing is a very, very valuable and useful tool to look at both the respiratory or the sleep and breathing aspects of sleep, and then the architectural or the sleep staging aspects of sleep. And then parents jot this down because a nap test, which is done during the day, can be added to sleep testing, even in school-age children. And some sleep physicians may not be aware of that. And then I'll pass it off to Dr. Amy to continue with the discussion.
So I think it's easy for us to order some of these tests, but it's easier said than done, right? So one of the I think it's the history and the physical exam is very, very helpful to start with. And I wouldn't want anyone to be frustrated with the fact that I live 4 hours away. My kid's not going to sit still enough to put those leads on. And so we are in an era of 2026. We live with phones. We live with data tracking. And so sometimes it's not feasible to get a sleep study. My kid's always sick. They're constantly having infections, and it's not the best time to get a sleep study. But my kid's super sleepy. We need the diagnosis. And so there's ways around it, not always. But sometimes going to the initial visit with your phone. This is my kid sleeping in a high chair. This is my kid at dinner time. This is my kid eating Cheetos, falling asleep. These are all examples that I've had in my clinic, by the way. And I think I want to empower everyone, keep talking about it. Because like you said, we're supposed to be experts. We're supposed to know everything. But PWS is still, there's a big vast of knowledge that we have to gain. And the more we talk about it, the more things that we use to get you the diagnosis and kind of figure out how do we tackle this daytime sleepiness and get that diagnosis, the more power to us. The reason why we're here is because we're talking about it. So I just want to empower everyone for that.
Well, we all have so much on our plate, to just give Lynn a break. We're dealing with so much, and that's why we need to keep circling back to these things and talking about them. We do keep talking about naps and daytime sleepiness, but I think something that's come up a little bit is that when you start to address the sleep issues, kind of the academic performance, and what we've noticed also is that it's not just like even when the naps are fixed, there's also like processing speed. And so when we started treating the sleep issues, Taya had a real boost in academic performance really quickly, because not only, I don't think it was just because she could stay awake all day, but she would say like she could find her words or she could engage socially, academically, all of those things in a way that she couldn't before. So, well, Lane, maybe hop over to you. You haven't shared yet. Tell us about your journey.
Sure. Well, Jim's 39 years old, so people didn't start really talking about sleep disorders till late in his midway through his adulthood. As you know, like other PWS babies, he slept all the time as a baby, and you just think that that's what they do. You had to wake him up to feed him, and then that kind of transitioned into as he started eating more real foods, and hard to keep him awake sitting in the high chair, and none of that really tracked for me as a disorder known as excessive daytime sleepiness because I'd never heard that term before. But he fell asleep at school. He didn't schedule naps. We never included it in his IEP, although maybe we should have. But he did fall asleep during school, and he was definitely, and sometimes still is, a car sleeper. Always a favorite family story that my daughter tells. We were in Colorado, and I was there for work. My husband and the kids decided to drive up Pat's Peak, the mountain, and my husband and daughter were petrified. It was so scary. And she looked in the back seat to see how Jim was doing, and he was sound asleep. He didn't care. He was sleeping away, climbing up Pat's Peak, and that was very typical for him. It was somewhat disruptive academically. We were able to kind of put things in place to help with that, especially in his elementary school. But really, quite frankly, he was a young adult. He was at a point where he was pretty heavy, and we had a sleep study done, and he was diagnosed with sleep apnea. I'd heard him snoring, so we had to do something. So that kind of became our excuse for daytime sleepiness. We didn't know better than that. He used a CPAP for several years. He lost some weight and no longer needed the CPAP, but the excessive daytime sleepiness continued. And that's probably when it really started to click for me. Wait a minute, this is a thing all of its own. I'm not sure what to do about it. I don't know how to deal with it. So it's a lot of the same issues, but with less information even than people with kids a little bit older had.
Dr. Ravana and Dr. Chittickle, Elizabeth in the chat talked about her child having kind of the opposite problem and not having a lot of energy, not kind of winding down at the end of the day. As I mentioned, and Elaine just talked about several different aspects of sleep issues. Can you talk a little more broadly about all of the different sleep disorders and sleep issues that we might want to look out for with our kids?
So, I just want to point out that one, when these kids are even kids who are typically developing, when they're sleep deprived, they can have ADHD type behaviors. They're hyperactive. In what I've seen in the PWS population, it's not atypical to see a hyperactive PWS kid or just keep going, keeps going, keeps going, is not sleepy. But maybe their keep going is their way of staying awake. And their way of adjusting to the fact that I want to keep going because I also have FOMO, but also the fact that if I don't stay awake, I'm going to miss out on, or I might get in trouble, or I might, the teachers are going to get mad at me, whatever the case may be. It might be a way for them to kind of keep up with things. And so I think getting that history and physical and talking to someone who knows about sleep issues in PWS is really important. In sleep issues in general in PWS can vary. It starts off with having an atypical sleep schedule. They're sleepy all the time. Usually it's the activities that are revolved around sleep, right? So in school age kids, they should be able to run, play, do after school sports and whatnot, participate at dinner, go to sleep on, at their time of when it's time for bed. These kids are not like that. Sometimes they're catnapping throughout the day. Sometimes they can be fidgety right before bedtime. They might have a little, or they move around a lot in their sleep. Some have trouble falling asleep. They can't wind themselves down, and they're just not able to get comfortable. Some may have hallucinations, and they don't come out and frankly say, I can see things or I can hear things that aren't really there. That's around sleep. And so I think that's what clouds and kind of pushes things away is that, oh, this is PWS. And you get that fallback answer as far as, oh, these are parts of the brain that's malfunctioning or not well developed, and therefore you're going to have these symptoms.
Maria, I think just to come back to sort of general sleep disorders, one way to classify them is those that have to do with breathing and those that have to do with the other aspects of sleep. Elaine mentioned a little bit about obstructive sleep apnea. Obstructive sleep apnea is common in all children. It's the most common thing for us to see in a general sleep medicine practice, and it's certainly something that can occur in children with PWS as they can occur in any other individual. In young children, tonsils, adenoids, congestion can be a part of obstructive sleep apnea or sleep disordered breathing in children with Prader-Willi and other kinds of, or really even typically developing children, if you will. And then reduced muscle tone can also affect the ability of the airway to open completely or normally during sleep as well. And so there are going to be some issues with respect to sleep and breathing that need to be attended to in children with PWS, independent of the non-respiratory aspects of sleep. And then the non-respiratory aspects of sleep is a very broad category of things. We've talked a lot about excessive sleepiness, but everything having to do with sleep hygiene, where you sleep, how you sleep, the ability to settle. Those are discussions that really need to be individualized when you bring in developmental differences in any individual child.
So Dottie just showed us a real world example of sleep issues in PWS. And then in the chat, she mentioned, wanted to know if lack of REM sleep is a major cause of EDS, and if so, is there a remedy?
So it's not the lack of, I give the example of a pressure cooker. And I hope this is not outdating anyone, but the pressure, the drive to sleep increases to a point where you lift that valve off and they fall asleep very, very quickly. And so once you relieve some of that pressure to sleep, they're usually these kids are well rested or they feel refreshed immediately. They're ready to go. And that could be a 10-minute nap. It may not even be that long of a nap. And so the issue with PWS and REM sleep is they have more REM sleep. That's the issue. And the tendency to drop to sleep is much, much higher because of that part of the brain that's affected. The remedy, that's what the clinical trials are looking at. And so for now, there are some medications that we use for narcolepsy and hypersomnia to help. They all have side effects, but there's some that are better at helping with the daytime sleepiness than others. But none of them are perfect. But I do think it relieves some of that sleep pressure that they experience.
Thank you.
Right, and I can quickly add the metaphor that I use sometimes is a short circuit between wakefulness and sleep that occurs in people with excessive sleepiness and particularly narcolepsy. And so whether it be a pressure cooker or a short circuit, I think those are both very apt metaphors, I hope. A couple of parallels here. I'm struck by what we often talk about in people with narcolepsy and how long it takes them to get diagnosed. And that's a broader cultural discussion about sleep in the United States and sleep in our culture, about how it's something that needs to be emphasized and needs to be given more importance greater importance for everybody. But this is such a great start on that discussion in this group of individuals.
Harley in the chat was asking about metrics to track. So, Dr. Ravani, you talked about using devices, which is a great suggestion. And she was mentioning that her daughter, I think it's a daughter, they use the Aura Ring. But what are some metrics that people, either the caregivers here are tracking, or Dr. Ravana, Dr. Chetical, what should we be looking for, tracking specifically?
Dr. Aaron, you want me to go? You want to go?
You're younger than me, so you can talk about devices and tracking.
Oh,
Give my
okay.
two
So
cents when you're done. No pressure. Sorry.
it's okay. Well, I mean, so some of these devices, so most of these devices are based off of movement. They're getting fancier. Some of them now can do heart rate and breathing and whatnot. And so, you know, I think it's important to one, track how much sleep duration. So, if the Aura Ring is recording 14 hours of being still, no one can stay still for 14 hours unless you're really truly sleeping. And it has to be, and it'll show you consistency. So some of these tracking devices can have like reports of how much sleep you've been sleeping for a month at a time, 2 months at a time, 3 months at a time. And for a sleep person, that's very helpful to see. It also is the timing. Are they sleeping, at midnight to 6 a.m. or are they sleeping, at 6 p.m. or 7 p.m. all the way out to 7 a.m. or 8 a.m. So, those trends are important. Then you can go into the nitty gritty. Some of these will tell you how much REM sleep you have. And, those are all great. But I would say look at the big picture. I wouldn't focus too much on the various metrics because they're mostly based on movement and light exposure. So be careful of that. But I do think it's valid for those that, you're not listening to me. You're not hearing that this can't just be a PWS issue. There must be something else that you can do to help. And here's my data. Here's my, we're scientists. We like data. We like to see trends. We like to, video recording of abnormal sleep patterns. I think are going to be very helpful and advocating for your kid.
Right. And you can use that
I
data
can just
to get.
mention, I can mention very quickly that there are also validated questionnaires that can be used in the clinical and the non-clinical environment, sort of the low-tech solution to what Dr. Amy just mentioned. And all of those things were sort of beautifully brought out organically in the discussion. Falling asleep in the car, falling asleep in class, falling asleep while eating, falling asleep at times when it's very unusual to sleep. And that basically is the Epworth Sleepiness Scale. And there is an Epworth Sleepiness Scale for childhood and adolescence. And then there are other sleep questionnaires that can be used throughout the developmental trajectory of a person that can help a clinician or a parent to decide whether or not an individual they love and care about is sleeping too much or in the wrong place at the wrong time.
Can I pipe in as just kind of a real world parent kind of experience here? It doesn't necessarily relate specifically to EDS, but when my son was an infant, and I remember, taking him home from the NICU and having that initial freak out moment because I wasn't sure if he was going to be asleep or if he was going to be awake or, how I was going to be able to measure, what was going on with him after you get out of the NICU with all the beeps and the squirks and when stuff is not going right. And I had this little foot monitor that I got for him, and I wish I could remember the name. And he's 8, so I'm sure like it's the technology is like far surpassed even what I had. But I remember I was able to track his breathing, his heart rate, his body temperature. It was like so many different things that I was able to track. And as a result, I had it for the first like 4 years of his life because as he got bigger, they ended up making it a bigger size of this little foot monitor. And I was able to use that when we were meeting with his physicians, and I could say, hey, look, here's all the tracking that this device had. And I knew that he was starting to get sick here because his temperature would go up, his resting, body, you know, beats per minute were going up. And I always knew within 24 hours of when he was about to get sick or have some other symptom that something was about to happen. And I was able to show that to his cardiologist and a couple of the other physicians that we had. I think we had like 8 specialists those first few years of life. And I was able to show them all that tracking. And as a result of that, we were able to get appointments faster. We were able to, when we had to do a 24-hour EEG, we were able to get that appointment faster because I was able to show them proof of what was going on at home. So, I mean, although some of these home tracking devices aren't perfect and they're not an overall solution, if I think if you have access to them in the real world, physicians are starting to pay attention to them more than they were. So I don't think it can hurt.
Yes, even old physicians like me, I completely agree with you. Thank you.
Elaine, have you and Jim developed strategies over the years that have helped him to manage the daytime sleepiness?
Probably I've developed more strategies than he would like. He doesn't live at home now, but when he was living at home, church on Sunday mornings was always a challenge, and he would usually sit beside me. And I developed some very subtle kind of, nudges and to kind of rouse him again, so that he would kind of be awake and alert. My concerns I've always been concerned about what is this and why is he sleeping all the time, but also socially. It was really, I mean, our kids have trouble socially anyway. And if their reputation is, yeah, they always just fall asleep, that's, and, kids can be really cruel. So social has been a real challenge as well. So I would, if I was around to help, I would try and kind of help him to stay awake. Thinking about the social implications. He also, this isn't really what you asked, but I wanted to share also as an adult. Several years ago, he had an opportunity to train for a possible program, for a possible position with a day program as a caregiver. And he was really enjoying it. And then one day he was placed in a very quiet, just a few clients. They were very quiet. It was kind of boring. And he fell out of his chair. And the staff for the program panicked and shipped him to the ER right away, thinking he'd had a seizure, which he's had in the past, but thinking it was a seizure or something. I am sure he fell asleep. There was no stimulation. And so the stimulation piece has always been a challenge, has always been something we tried to do, even as a kid. What do we need to do to kind of keep him stimulated, keep him awake, keep him paying attention to what's going on? But he lost a possible job opportunity because of excessive daytime sleepiness, which is a really big thing in our world as well, and I'm sure others can relate to that.
Well, I remember back when Tay was in second grade and we were talking about the sleep issues, and I asked Dr. Glaze. I thought it was strange because Taya would fall asleep at school, but then have plenty of energy during the weekend. I'm like, okay, that's convenient. But he did say the same thing, that it matters, like the stimulation matters, if she's doing things that she cares about and is excited about, that she might not be as sleepy. Also, you can't make this up. Taya is taking medication, and we're having a kind of a gap due to insurance issues. She literally just texted me, I'm not feeling good. My stomach is bothering me, and I'm feeling very sleepy. I was feeling the same way in school. It's not because I'm hungry. You can say no, but can I skip swim today since I don't feel well? She loves swim. Yeah, I know, Dr. Urbana. But what I was going to say is, I think once, especially if your kids are able to articulate, once they have felt like they've had the sleep issues under control, they're also a good source, because she can tell when she's not feeling up to things because she's sleepy.
So can I just mention, so medications, yes, but these kids sleep. And so sometimes when you're trying to wait for the insurance approval and all that, we try different modalities like the caffeine, the coffee, and whatnot. But remember, naps can be done anywhere. And naps do have a retribution in school. So you have to, as a sleep provider, I have to advocate and write tons of letters to say, don't punish the kid for needing to nap or put their head down. Don't give them more assignments either. But remember, they could, have two naps. So I try to get right for, or at least advocate two naps during the day until we get the medication started to release that sleep drive so that they're not missing so much. They don't need to sleep for 2 hours, but even 10, 15 minutes right before lunchtime or right after lunch, whenever, is so they're not missing class. And they're not missing something they truly, truly enjoy, but at the same time, not feel so crummy when they're doing what they want to do or love. So try to, even try doing experimenting on the weekends. Is what I usually tell families. Like, experiment what works for you guys around the schedule that you have. And so that way your kid gets to enjoy life and participates in life and not sleep through it as part of, despite the diagnosis.
And that's a great tip, and I for adults too, right? I can imagine, and it's probably even more difficult for the adults that are in day programs where napping isn't maybe as accepted. Um, Lynn, do you have any sort of insights there?
I'm so sorry. Um, as far as residential placements go,
Yeah, and how to manage the sleepiness, and have any tips, or is napping, something that they can incorporate into the day?
it's absolutely something we can incorporate into the day, but then there's also that balance, right? We want to, as residential providers, make sure that they are engaged in meaningful work, but we also want to make sure that they're engaged socially. And sometimes there is a balance. We have folks that would just rather sleep 10 hours of the day, and we don't want that. We want them to be engaged. And out doing things. And I think, one of the doctors mentioned, and so did you, is how do we elicit that? How do we get them active and involved in wanting to do things? And so we really try to do that and balance their own rights too, because some people will assert, this is my right, I just want to sleep all day. Well, that's probably not the best idea. Well, let's go do this. So we really do try to promote that and balance that with the assertion and their rights that they might just want to take a nap. So we do build that in for sure.
Hey, Lynn, I have a follow-up question on that. Like, what would that look like if you have an individual with PWS who's working, maybe not in a group home situation, but they're out in the world, they're either in a work program or they're working, a part-time job. What do you think this looks like in that kind of a situation? Like, how do we account for that?
Well, we have had a fair number of folks lose their positions because they were caught sleeping and it was dangerous. For example, we had someone that was working at a like doggy daycare center, and they were sitting down kind of with the dogs and they fell asleep. And it happened several times, and they ended up getting terminated from that position, which is their dream job. Oftentimes, if we know that this person is having excessive daytime sleepiness, this is something that, as providers, we will partner with the day program or wherever they're working to say, hey, this is a possibility. This person might need a little extra support or might need a break, and that's okay. But let's make sure that they have somewhere safe and not on the gym floor or whatever to just take a nap. And we don't want them to lose out on opportunities because of this either diagnosis or not yet diagnosed condition.
Okay.
Thank you. Before we open it up to questions, I know the team wanted to touch upon growth hormone. Dr. Chittickle, do you want to mention something about that?
I quickly in the context of sleep, that's often how people or infants with Prader-Willi syndrome are brought into our practice. Screening for sleep apnea in the context of initiation or continuation of growth hormone therapy. And so from that perspective, that's been one avenue for us to become involved in really, I'm a pediatric provider, so a childhood long, but a lifelong discussion and focus on sleep. And so, yes, with respect to human growth hormone therapy, it does provide the context for us to begin and continue a discussion about the importance of sleep and integrating sleep into the healthcare and the health maintenance of individuals with PWS. Human growth hormone therapy has been impactful in so many other ways for this condition in, obviously areas outside of my expertise as a pulmonary and sleep person, but from a standpoint of using the discussion and the screening around human growth hormone therapy to begin and then continue the discussion of sleep and to highlight the importance of sleep in this context is one area or one source of low-hanging fruit, and has been something that we've integrated into our practice.
Great, thank you. I want to have time to open it up for questions. If people want to just raise their hand and come off mute, happy to have you participate in the conversation. Dottie, I saw that you had a question. Do you want to ask that?
Yes. My daughter has also been diagnosed with Parkinsonism, and I'm wondering what impact the medication carbidopa levodopa, which she takes 4 times a day, what impact that might have on daytime sleepiness, if anyone has any information or history on that.
It can make you sleepy. It can, depending on the dose. So I would suggest talking to who's who's prescribing it. Sometimes you can play with the dosing as far as timing of the dosing. 4 times a day is pretty much all throughout the day, right? And so it can be very difficult. But again, I would suggest talking to the provider, you know, this is impacting daily function. Yes, is there a possibility to decrease the dose or change the timing of the dose to see if that makes a difference? Sometimes it does, sometimes it doesn't.
Thank you.
Thank you.
Agnes?
Yeah, hi. My daughter Diana is 30 years old. So a lot that you're talking to, I'm so happy that people are more aware of it now. Because when she was going through school, I would say she needed a nap at 1 o'clock. If we respect that, you probably get better benefits. But the school wasn't really willing, and she had more behavior, and therefore eventually it became a downward spiral and she failed out. She is in a residential program right now. Um, she does have a CPAP, which I found very helpful for her sleep, her quality of sleep. As far as sleep, I noticed if she has a nap a day, that's good. But when you're starting to get to that 2 or 3 hours, then to me, that was always a red flag. Something's wrong here. Is she getting sick? So I share that, know your child. As one mother says, she always took, the temperature and that information, you know, that's always helpful. As far as a family, we always accommodated diet with, her naps. Like, we always bought a car that the chair reclined. So her neck wasn't leaning over, or we had to use a neck guard. We could always make sure that um, she could always fall asleep, because as soon as you got in the car, we always used to joke, Dice asleep, for the most part. My concern now is we are using a sleep map, and we are using, psych meds. And I know, again, the psych meds, I'm thinking that we're working with that right now, actually discontinuing one, because I'm finding her sleeping a lot more during the day. But the sleep map, like I say, the data on it shows, I asked how many times did you wake up last night? She told me 3, but the sleep map is telling me that she woke up 5 times or 6 times. And I'm trying to find out, like, is that, how accurate are those sleep maps in that? Is it something, I'm still trying to work through that. So
Dr.
I'm just
Ravana, have
trying
you
to,
heard of the sleep mat?
Yeah, I don't have any data or any, I know, ironic, anything to prove that it's valid or invalid. But I think it's more of how you're using it. So if, like you said, if you know she wakes up this many times and she's more sleepy, and you go back and you kind of correlate it, then maybe it might be helpful. Um, a lot of these, I, I always look at PWS kids as they're not going to follow the norm.
right,
These devices are going to follow the norm.
right.
And so even subtle movements may not be picked up. So it's hard to tell if this is reliable or not. Now, if they're drastic movements or a lot of awakenings, like 15, 20, 30 times, overnight, maybe, there is a component of sleep apnea and they're startled or they're jerking in their sleep, or maybe that's a flag for you as I have to raise this up with somebody. So I don't, I sometimes I shrug my shoulders and just say, okay, I get that you're using this as your way of assessing, but maybe we should look into the history and look into questionnaires and maybe get that sleep study that we really should get to kind of identify what's happening and then go back to the sleep map and correlate it with that.
Yeah, I agree with you totally. Our children are unique, and the information that you have, just, they write the story, we read it afterwards, I always say. But it's a piece of information, and thank you. What about the temperature, the heat versus the cold? Does that affect, I'm trying to think of different things that could be affecting her sleep quality too, or her wanting to sleep, the room too warm.
Yeah, that's an easier question. Cooler environments are better for sleep because of how our circadian rhythm for body temperature works. Entering the main sleep period, the circadian rhythm for body temperature is moving the body temperature to a lower place, and having a cooler sleep environment helps promote that and does improve sleep quality in that way.
Okay,
So cool,
thank you.
dark, quiet.
Right. And then the
Oh,
last question is, if she has coffee too late in the day, she says it affects her sleep. Is there any data that can give me or any kind of article that would be helpful to me to share that?
That's another easy one. That's just true. Caffeine promotes wakefulness, and everybody's system metabolizes caffeine a little bit differently. And so, for some people, taking caffeine too late in the day does impair overnight sleep. As a general rule, again, not necessarily for people with excessive sleepiness, but for the general population, we would say limit caffeine after lunch as a way of maintaining healthy sleep and promoting sleep onset at a good time at night.
thank you. I want to quickly get to the other two questions. Jennifer, do you want to come off mute?
Yes,
Thank
hi.
you.
Silas is now 5, and because of his daytime sleepiness, he's only been going to pre-K 3 and pre-K 4 now in the morning. Um, with his IEP, we're meeting several times a year, but we're trying to trial him adding on the PM session, which we've done recently, Dr. Chitico. Um, with that being said, we have adjusted pickup time for 2 o'clock instead of the end of the day. With him doing that, he's sleeping for like 5 hours when he comes home. Like I'm having to wake him up like by 6 p.m. to eat dinner and then go back to bed by 8:30, and then he'll sleeps all night. So my question is, I know like he's too technically too young for the pitolisant. We tried the whole modafinil thing, that didn't work. Um, what is the latest, I guess, with phase 3 trial, and possibly somebody in the community said that they got their kid on pitolisant before 6. Just curious about that, or like, what do you think the trajectory would be in December when he turns 6 for him to be on the pitolisant?
Well, the phase 3 study, the age of entry is 6 years. And so we can certainly discuss Silas's candidacy to enter the study at that time. Full disclosure, I know Silas and Jennifer very, very well. We were unable to get modafinil. I think he would be a perfect candidate for that. The other option that we can talk about is doing the sleep testing with the daytime nap testing to try and either confirm a diagnosis of narcolepsy or to document how excessively sleepy I mean, we know he is, and then using that as a way of trying to drive the insurance company to approve medications off label. But he would be a wonderful candidate for phase 3. And as long as the study is still open at that time, but we can certainly investigate having him come for sleep testing while we. And this is another great example of working with the school, working with an IEP to try to come up with a program that works for each individual child.
All right, we have one more question. M. Saravina, I'm not sure your first name. Do you want to come off mute? Okay.
Oh,
Well,
sorry about
oh, go
that.
ahead.
I'm off mute. Really quick question is, so my daughter, she's 32, 31, but she's just so of course I'm of the generation where we didn't have as much focus on the sleeping and had all the challenges going through school as well with sleeping during school and everything. In the last couple of years, she's had more of the night terrors or the waking up or the yelling at night and the talking sleep at night. So we finally got her in line to see a pulmonologist, and they're finally going to do the sleep study to rule out or rule in parasomnia. And this pulmonologist is not as familiar with PWS. I mean, he's been great because he's relying on a lot of the information we are providing to him. But what other resources could he use, or who could he reach out to if he would need more information to see within the realm of PWS and her age? Is this normal? Is this not normal? Those kind of collaborations.
Well, I'll just say quickly, it's great that sleep testing is going to be done. If you haven't, grabbing some video of those episodes can be very, very helpful as part of the clinical evaluation as well. Sleep disorder breathing and other things that cause sleep disruption can worsen or unmask parasomnia. So there may be something that does come up as a quote unquote cause or linkage to these events. In terms of adult care, I'm less familiar, so I apologize for that.
All right, we are at time. We're over time. Thank you everyone for joining. I wanted to just do a quick, go around the room and what is one thing that each of you would like to leave the community with. And I'll start with you, Dorothea, since you're good at breaking.
The ice. Thank you. I think one thing that I would just like to leave everybody with is that, if you're curious, like if the question has even come to mind, like, could this be excessive daytime sleepiness? Could there be a sleepiness issue? Don't second guess yourself and think that you might be overreacting or that this is just part of a diagnosis. The more that we learn about PWS and the more that we're able to break down the symptoms of PWS, it is unfair to our loved ones living with this disease to just lump in that they're going to have sleep issues because they have PWS. There's real research happening now. There's real development, real therapies that can help our families. So if you have a hunch that your loved one might be suffering, don't second guess yourself and think that you're just overreacting or just an over concerned parent. Have it checked out, talk to other families, talk to our sleep specialists working in our space. I know it's another thing on our plate and it's hard to kind of keep up with all of the aspects of PWS. But have it checked out. Best case scenario, it's nothing. Worst case scenario, you're a proactive parent.
Thank you. Lynn?
Well, Daryl summarized that very nicely. If you see something, get it evaluated, right? And just keep in mind all these other things could be attributed to sleep. There's so many things that sleep touches. It's the behavioral issues. It's the not disengagement. So really cue in on that. And if you are even thinking about it, like Dorothea said, get it evaluated. And if you need help advocating, we're here to help you.
Thank you. Elaine?
We've never done a clinical trial before, and we are now on the trial, on the Harmony trial. So we are working right now with the population that are trying this drug for excessive daytime sleepiness, trying the pitolisant, and it's been good. I can't say it's a complete life changer yet, but he's definitely sleeping less in the car. He sat next to me at church Christmas Eve and did not fall asleep. That was a big note and that was late in the day, so that was exciting. So I think you do want to pursue it. You do want to try and get testing done and see if there are options for you to participate, drugs that you can use now or things like this clinical trial that you can participate in. Don't be afraid of it.
Thanks, Elaine. And Dr. Ivana?
I think you guys summed it up for me, but keep talking about it. Keep asking questions, keep fighting for your kid. You're the only one that can advocate for them, even though as physicians, we advocate for you. But as mama bears, like, you got to do it. And so I empower all of you. Thank you so much for taking the time to listen to us today.
And Dr. Titical, last but not least.
Well, thank you for having me. Boy, this is a different story than it was 30 years ago. You guys have come so far, and it's this kind of discussion, this kind of energy, this kind of unmasking that is enabling the forward motion. So thank you, and keep up the great work.
Thank you. And I would say just share it with as many people as you can. Keep the discussion going. Talk about all the things and keep, sleep top of mind as something that might be contributing to all of the things that our kids are experiencing. Thank you so much to all the panelists. Thank you to everyone who took time out of your day to be here. I look forward to continuing this conversation. Thank you.